Today we start our lecture from general questions in traumatology, and the lecture will be dedicated for fractures of bones, their diagnosis, treatment, and everything you should know when you face with this problem. So what is fracture? A fracture is a break or disruption of the continuity of the bone, or the problem disruption with the normal architecture of the bone. It is a synonym of the break term, but break is widely used by non-professionals. In traumatology, in medicine, we prefer to use a term fracture. Sometimes you can meet the term crack of the bone. This is a type of fracture which is characterized by not complete destroying of the bone. Mostly cracks are happening in young patients and in children. Because their bones are more stronger, and especially children, they have very good developed periosteum. And in childhood, we are facing to the fractures, green stick, so-called green stick fractures or cracks. So sometimes it is psychologically for people is better to hear a term crack, but not the fracture. They are afraid of this term fracture, so sometimes they prefer to hear a crack. But it is a synonym. So fractures is a disruption of the bone, of the continuity of the bone, of the architecture of the bone. There are a lot of bones in our body, and each of them can be fractured depending on the situations. So complete and incomplete fractures. Here you see the good picture, which is depicting a crack of the fracture. It's a childhood fracture, a child's shin. You see the growth zones nearby the ankle, and you see that there is bone disruption, but with very small displacement, but still the anatomy without severe displacement, but still anatomy is preserved. So traumatic injuries. It is very important when you put the diagnosis. It is very important to put the etiology of the trauma. First of all, it is traumatic injuries, stress fractures, and pathological fractures. The most common are traumatic injuries, which are caused by different types of trauma: direct trauma or indirect trauma. Stress trauma, the stress fracture, is the type of fracture which is more common, for example, in athletes or the military forces. It is the result of repeated stress and strains movements in the segment, in the affected segment. In most common example is the fracture of the metacarpal bones in military forces when they are marching for a long time. They are marching, they are going for a few hours, and this repeated overload of bone is caused the stress fracture. And pathological fracture, it is a spontaneous fracture of the bone which are affected by other diseases. For example, tumors, metastasis, or something like that. So pathological fractures. According to the type, they are classified for open and closed fractures. Open fractures are fractures when we have damage of soft tissues, and that's caused the communication of the external environment. They are very complete problems. Is complete fractures, open fractures. They are more complete than closed fractures. It is always cause the bleeding, severe bleeding, and the high risk of infection complications of the fracture. Open fractures can be primary opened and secondary opened. Primary open fractures is situation when the damage of the soft tissues was caused on the site of the trauma, and the secondary open fractures are situation when the damage of soft tissues was caused after different manipulations with affected limb. For example, when you perform insufficient immobilization of the limb, or you are trying to do some tests, so it is secondary opened fracture. Besides, they are fractures are classified by anatomical locations of the involved bone. So, besides open fracture, they can be opened from without to within and from within to without. From without to within, for example, as it is depicted by different sharp things such as knives, sticks, and so on. And the other way, when the bony fragments are penetrating the soft tissues from inside out. And types of fracture, as I told you, they are different. First of all, you see the classification here. First of all, the fractures can be interarticular and extraarticular. Interarticular fractures are fractures when the line of the fracture is laid through the joint capsula. So it is interarticular fracture. When the line of the fracture is lined out, outlines the capsula of the joint, they called non-interarticular simple fractures. According to displacement, they can be with displacement or without displacement. According to the plane of the fracture, they can be longitudinal, oblique, transverse, spiral, impacted. And there is a special type, so-called avulsion fracture. Avulsion fracture, it is a situation when the muscle pulls on the bone and fracture it with a small fragment, which is called enthesis. Enthesis, it is a place in the bone where the ligament is attaching to the bone. So avulsion fractures. According to anatomical location of long bone, it is classified by the fractures of the proximal, middle third, and distal third, or the fractures of shaft or diaphysis, the fractures of metaphysis, distal or proximal metaphysis, or epiphysis. So according to the anatomical location of the bone. What are the clinical manifestation of the fracture? What are the signs of the fracture? Of course, it is pain, loss of function, deformity, shortening, crepitus of fragments of the bone, swelling, dislocation, muscle pain, and tenderness. First of all, pain. Of course, when a patient is suspected for fracture and you are interviewing it, you are gathering the anamnesis, the first complaint is pain. Pain is not specific symptom for fracture. Pain is a non-specific symptom. It can be caused not only by the fracture, by a simple trauma of soft tissues. It can be caused by dislocation, subluxation, and so on and so on and so on. Pain. Pain is, in most cases, localized in the site of the fracture, but you must remember that there are situations when the pain can irradiate to the other anatomical region, not concrete in the site of fracture. Irradiation pain. So pay attention when you are asking patient about pain and localization of the pain. Loss of function and loss of function. A lot of people believe that when the bone is fractured, a patient can't move the limb. No, patient can move the limb in the case of a lot amount of fractures, a lot of type of fractures, and sometimes when it is fracture of some bones of lower limb, these patients can even walk for a few days or even sometimes for a long time. So loss of function is present, but it is not obliged symptom to deformity. In the case you have a fracture bone with dislocation, you can see the deformity or shortening. If there is undislocated fracture or the fracture of the bone which is surrounded by a big amount of soft tissues, you can see no deformity, you can miss this deformity, and you can miss sometimes shortening. Besides, deformity can be caused by severe hematoma. When we are talking about soft tissue damages, which are combined with damage of the vessels, you will see the deformity which will be caused by deformation of soft tissues. Crepitus is very important symptom, but don't try to test it on your patients, especially when when these patients are not undergoing the anesthetics. They are not under anesthesia, because it is very painful symptom and it is very dangerous, because when you are trying to feel this crepitus, when you are moving the broken bone, you can cause the secondary penetration of soft tissues by bony fragments, or what is more frequently, you can cause the damage of vessels of peripheral nerves by bony fragments. So crepitus is present, but don't try to test it. Besides, if you will have fracture without dislocation, you start testing crepitation, you can cause the iatrogenic dislocation. So don't try to do it. Swelling and dislocation, as well as I told you, when we have traumas, we always have swelling, muscle spasm because of pain, and tenderness because of painful situation. When we are talking about fractures of large bones, such as hip bone or pelvis, we can receive combined big loss of blood, big bleeding, internal bleeding, up to few liters of the blood. In this case, we can observe that the patients suffer and they are looking pale, clammy, can cause dizziness, sickness, sometimes nausea and loss of conscience. The same situation we can observe in patients which are suffering from multiple traumas, multiple fractures and combined fractures, and severe open fractures with damage of blood vessels. How can we put the diagnosis of the fracture? First of all, we are gathering during the interview the complete history of the trauma, all circumstances which caused this situation, and very special attention we are paying for mechanism of trauma. Some special traumas have very special mechanisms of trauma. For example, when the patient is jumping from the high and landing on the foot, it can cause the fracture of bones of the forefoot, or when the patient is fallen, for example, when the patient is diving in the water and there is very few water thickness, it can cause a very important, very dangerous fracture of cervical spine, of vertebrae, so-called fracture of diver. So mechanism of trauma is very important. Then we are evaluating the symptoms, local, general symptoms such as pain, swelling, tenderness, and so on. And the gold standard for diagnosis all types of fractures is X-ray. X-ray is gold standard, and X-ray is sufficient in most cases of fractures. Most cases. In some cases, we need. Extra investigation, extra tests such as computer tomography or MRI. It is needed when we are planning the operative treatment, or sometimes when we are talking about fractures of small bones, such as bones of the forearm, or fractures of complex anatomical structures, for example, elbow or vertebrae, when we need to evaluate the risk of spinal cord injury. What can we evaluate using X-ray? X-ray is very cheap and popular method of diagnosis. As I told you, it is sufficient in most cases. First of all, we can localize the level of the fracture and evaluate the number of fragments of the bone. We can indicate and see the degree of displacement. Is it severe displaced or not? And then we can think about reposition. Does it need reposition and the type of treatment? We can evaluate if this fracture was pathological. We can see some changes, pathological changes in the bone during X-ray. We can evaluate the presence of foreign bodies when we are talking, for example, about gunshots. It can show us the other fractures which can be missed during your physical examination, because they will be hidden by the main big fracture, so-called main fracture. Yes. When we use extra tests, as I told, MRI and computer tomography, ultrasound, we can evaluate the damage of soft tissues, the damage of vessels, peripheral nerves, muscles, ligaments, and so on. You must remember that X-ray is performed no less than in 2 planes. Why it is so important, you can see on this picture. Why it is important to do X-ray in no less than 2 planes. Yes. There is a so-called rule of 2. We always advise to use, yes, in 2 planes X-ray 2 times before and after immobilization. If we have any doubts in presence or absence of deformity, in presence or absence of fracture, especially in the case of small bones, when we have some anatomy anomalies and we don't know how to evaluate it, we can do it 2 sides, healthy and affected side. So 2 arms, 2 legs, and then we can compare what we see on the right side, on the left side. And it is very important to make X-ray to see 2 joints. 2 joints, one joint proximally and one joint distally to the fracture. Because in case of spiral fracture, in the case of fractures of segments where there are two bones, for example, forearm or the shin, we can miss the additional fractures which are placed higher or lower to the main fracture. For example, it is very common situation when we have significant fracture of the distal third of the shin, of the tibia. It is very often combined with the fracture of the proximal part of the fibula. So always try to make X-ray of two joints. They must be depicted on the X-ray, the proximal and distal joint, which is neighboring to the fracture. You must remember that orthosurgeons merely treat the fracture, but only the God or the nature is cures it. So regeneration of bone is a physiological process. We can't change this process as we want to make it more faster or to slower it. It's a natural process. Only thing we can do is to help the nature to cure the damaged bone. And our help depends of different our treatment depends of different situation and different phases of the trauma and the place where we are helping the patient. Emergency care begins immediately as soon as it is possible in the site of the accident. The main reason, the main rule is to splint the damage where they lie. In most cases, this emergency care is performed on the street, far from the hospital, and you use everything you have on your pockets, on your bags, on your first aid in your first aid box in your car to help the patient. What means splint them where they lie? If we are talking about fractures, if you see the patient with fracture, open fracture with, or the fracture with deformation, don't try to perform reposition or don't try to hide the bones inside the body. You only use immobilization, transport immobilization, and close the wounds with clean bandages. Don't try to do anything else. Use your available objects such as newspapers, different sticks, pillows to immobilize, to make a splint of the affected joint. If it is combined with severe bleeding or when we are talking about open fractures, you can use a tourniquet or pressure proximally to the site of the bleeding, proximally, not distally. We don't use distally tourniquets, only proximal tourniquets. We can close the wound with clean clothes. We can make splint and we can make a transport immobilization. That's all. If you have some remedies, analgesics, you can use it. You can wash the wound with clean water or antiseptics, but no more. And then you are waiting doctor, or if it is not possible, you can transport the patient to the hospital if it is safe. In the district level hospital, the nearest hospital when the patient is admitted, the transport immobilization can be changed for more stable immobilization, back slabs, collars, slings, tutors, so on. Special immobilization, which is more stable. And then the doctors are acting according to the situation. Analgetics are given for patients, fluids are injected. The bleeding can be stopped by a surgeon if they are present. Transfusion in the case of blood loss, anti-tetanus toxoid treatment. Don't forget about this, antibiotics, and so on and so on and so on. In this case, in this level, you can perform X-ray to understand what you are facing about. You can perform different other tests, and you can plan your next step in treatment of this patient. You must remember that not all fractures need special treatment. For example, fractures of the rib don't need a special casting or splinting. They are painful. Of course, if it is, if we are talking about isolated fractures of the rib without complications such as damage of lungs or pleura. So analgetics and rest for patients is enough. It is painful fractures. It will be painful for few weeks, even sometimes for few months, but you should not use a special casts or immobilization. Open fractures have a specific treatment. It's a specific treatment needs open fractures, such as wound care. So clean clothes for wound, antibiotics, prophylaxis, rest, and take decision about future treatment of this fracture. Open reduction, close reduction, immobilization, and in the case of open fractures, it is not recommended to suture, to make suturing of the wound. It is better to perform, to hold this wound open, because the increasing edema and can cause severe complication, and a severe complication is anaerobic infection. So open fractures, it is not recommended to be sutured just after the admitting to the hospital. We are washing the open wounds with antiseptic solutions, cover after cleaning with clean gauze or bandage, leave wound open, use different types of immobilization for different segments, evaluate position of the affected limb, and of course, as we told, anti-tetanus toxoid, don't forget about this. Anti-tetanus prophylaxis is very important because it is a high risk of anaerobic infection. What are the goals of treatment for our patients? First of all, it is to restore the anatomical alignments of the limb, to hold the immobilization for all period of treatment or regeneration of the bone, and to restore the normal function, to help people live healthy and healthy life, and to have good quality of life. If you evaluate the fracture as fracture without dislocation, You can use closed fracture without dislocation, without any complications. You can use a simple casting, and in most cases it will be enough. In the case you have diagnosed the fracture with dislocation, it needs reduction, reposition. There are two types of reposition, even three types of reposition. It's closed reduction, open reduction, and the other one is continuous traction. Closed reduction, it's non-surgical manipulation. We always are trying to start with closed reduction for most fractures. The closed reduction is always performed with anesthetics. Don't try to perform reduction without anesthetics. It is very painful procedure, and it can cause shock, loss of conscience, and sometimes the risk of such complication as compartment syndrome. When our closed reduction is not enough, when we have faced the complex fracture with multiple fragments, we are thinking about open reduction. Open reduction is a surgery procedure when we use incision, when we use different fixations, bone for bone, metal plates, pins, nails, and so on. And there is a continuous traction. Continuous traction is a method of reposition when we use traction to remove the dislocation. It is widely used in the case of multiple trauma and in the case of open fractures. The most popular treatment for fractures is plaster bandages, immobilization with plaster of bandages. It is widely used. There is different types of bandages. Some of them are contemporary. They performed with different plastic materials. They are light, and they can help patients to live more quality life. What are indications for plaster bandages? It is undisplaced fractures, incomplete fractures, stress fractures, fatigue fractures, without significant displacement, or after the reposition when you receive a good anatomical result. The main rule of the plaster, of the casting, is to immobilize proximal and distal joints and to leave the distal part of the limb free of cast, to evaluate the color of fingers, to evaluate the temperature of fingers, to avoid the possible complications of compartment syndrome. There are some special types of casting for different traumas, as you see. It's short arm cast, long arm cast, double hip spica, and so on for different types of fractures. Traction. There are several types of traction. It is skin traction. It is widely used in pediatric traumatology when we use a special glue, and this glue helps us to hold the traction. And skeletal traction when we use special pin which is going across the bone, mostly used in adult. That is historic picture, it is not a new method. It was well known a long time ago when we put a traction, and this traction is leading to the slow reposition of bony fragments. We use this method to reduce a fracture or dislocation, to retrain the fracture after reduction, and it is very useful to overcome the muscle spasm, traumatic muscle spasm, which is just after the trauma. When we are going to make a surgery, it is very difficult to overgo this muscle spasm, especially when we are talking about such massive structures as, for example, fractures of the femoral bone. Yes, there are a lot of muscles. The limb is shortening, the muscles are spasmed, and to overcome this spasm, we use traction for a few days. That's how the skeletal traction is looking like in nowadays. A special device, a special pin which is going across the bone, a weight, different weight for different segments, for different patients. If the patient is sick, we use less weight. And this traction is used until we receive a positive result of reposition. After that, in most cases nowadays, we are performing a surgery. Previously, 20, 30 years ago, when we were poor of medical supplies, of different fixators, this traction was used for a long period, for several weeks, and then we can put a cast. So it's long period, the patient is lying in the bed. The quality of life is not very brilliant, so it needs a lot of care to take care about the pins. So the patients were not very happy. So now we use traction only as a period for treatment, short period, as short as it is possible for future surgery. As I told you, the skeletal tractions have some problems. What are the indications for open reduction, operative management of the fractures? First of all, there are absolute, relative, and questionable indications. Absolute indications is, first of all, fail of the closed reduction. When you have tried to do a closed reduction for a fracture, after you perform this closed reduction, you put a cast, immobilize the damaged fragment. You always perform the next X-ray just after your closed manipulation. You must evaluate the result of your manipulation. If you achieve a good result, you restore the anatomical alignment, you can stop and treat the patient conservatively with casting. If you make an X-ray and you see that the result is not sufficient, you don't receive the complete reduction of the displacement, you can repeat your effort to make reposition again. It is not recommended to perform a lot of closed repositions in one patient. If you don't receive a good result after the second attempt, you'd better think about surgery. You cannot receive a good result for different reasons. First of all, it can be multiple fragments which you can miss on X-ray. Besides, one of the most common reasons why you can't reach good reposition is soft tissue, which are placed between the bony fragments. for example, a piece of muscle or something, ligaments, some ligaments which are lying between the bony fragments, and you can't receive a good reposition. So when you failed, think about open reduction. Intra-articular fractures with displacement are 100% to be operated. You will not receive a good result. You will receive a fail of function. In the case, the dislocation will be present in the case of intra-articular fracture. Type 3 and 4 epiphyseal injuries, severe fractures. We will be talking about these types of fracture during our practical classes. Avulsion fractures will not receive good result for several reasons. First of all, when we have avulsion, as we told, a muscle is shortening, the muscle is spasmed, and this fragment of the bone is running away from the place where it must be. If the muscle is avulted, the function of this muscle will be lost, because the function of muscle can be performed only in the case of presence of 2 points, punctum fixum and punctum mobile, at the beginning and the end of the muscle. If this muscle is disrupted, you will not receive restoration of function. Non-unions and replantation of extremis. Non-unions is a complication, late complication of the fractures, and it must be undergo surgery. If the fracture is not healing, it's only you can help only by surgery. Relative multiple fractures. Multiple fractures depend on situation. It can be used surgery, it can be used conservative treatment. Delayed union. Delayed union and non-union are two complications. When we have a delayed union, we can still wait for some time. It can be treated conservatively. Delayed union. Non-union can't be treated conservatively. Loss of reduction. After you perform reposition, you put a cast, and you make X-ray. You receive good reposition. After 7 or 10 days after the fracture, you must perform another X-ray to evaluate the secondary displacement. Was your reposition enough, and was the situation still good? If you will receive the secondary displacement, loss of reduction, it is indication for surgery. Of course, sometimes doctors can use the secondary reposition, secondary attempt, if this displacement is not very significant. But it is good idea to recommend surgery. Pathological fractures, depending of situation, as you understand, depending of the reason of the pathology, you can these fractures can be treated both conservatively and by operation. For better nursing care, some types of fractures needs a long period of lying in the bed. For example, the fracture of the femoral bone, it needs a long, for 6 months, casting, crunches, and so on. So patients are lying in the bed, they feel not good. After performing a surgery, they can walk the next day, of course with crunches, but it's much more easier for them. And after a few months, sometimes after a few weeks, they can step on the affected leg without risk of some complications. So it improves the quality of life. What are questionable indications for surgery? It's neurovascular injuries, open fracture, cosmetic reasons, and economic consideration. Neurovascular injuries needs first of all to be revised for damage of the peripheral nerves and vessels. Fracture can wait for a few days. Open fractures as well. Sometimes it is better to use skeletal traction or then to perform the surgery. Skeletal traction can be performed for several weeks to receive the wound care. When you receive the wound healing, then we can do surgery on soft tissues which are preserved of infection. Cosmetic reasons as well. Sometimes cosmetic reasons are taken note, mentioned by surgeons. A lot of doctors think that cosmetic is not very important, but as time shows us that a lot of patients are suffering from cosmetic problems after the fractures, about scars or about deformation of the limbs, and it plays a great role in their lives. So cosmetic reasons must be taken into our opinion to add economics consideration. Of course, we must evaluate this economic effect of our treatment. If conservative treatment takes a long time, as we discussed, for example, fracture of the femoral bone, the patient is unavailable to walk, so it's much more cheaper for them and much more faster to recover to perform the surgery than wait for 6 months lying in the bed, having no possible to walk, to earn the money, to visit somebody. It's very difficult. So economics and social effects. What types of fixators during our surgery? We use different types of fixators such as screws, plates, pins, depending on what type of fracture we are talking and what do we have to do. We can use wires, we can use plates of different shape, press-shaped plates, non-press-shaped plates, plates with minimal contact, special dynamic compressed plates which allow us to improve the function from the very next day after surgery. A lot of depending on the type of the fracture and circumstances in which we have. Intramedullary fixation is very popular during last years because it is it's very popular because it allows the patient to rehabilitate very fast and with good, as I told, with good cosmetic effects with small incisions. The same nailing for the shin. If you are going to be a traumatologist surgery, if you are interested in it, you must know what is our group. Our group is one of the biggest associations of orthopedic surgeons in the world. It's a gold standard for our business, our medical job. In the case of trauma, you can visit their website. There are a lot of different interesting videos. There are a lot of different interesting solutions for different types. If you are the beginner, fresher, and if you are even a professional, it is very good idea to visit this site because on the site you can find not only texts dedicated to different types of trauma, but you can find a lot of classifications for different bone fractures and you can find a good solutions to treatment of different types of fractures. Which type of fixation it is preferred to use for this bony problem, which type of approach we can use, what are the main points of the surgery, what we should to avoid, what we should wait, how to rehabilitate the patient. So a lot of very interesting and important information. So our association is free website. The same. Open fractures. So how we treat the open fractures? Open fracture, as I told you, it can't be treated as a closed fracture. These are different types of problems. The other one important method of operative treatment which is widely used for open fractures is using the devices for external fixation of the bone. This is not a new method of fixation, not a new method. It is well known and widely used in all over the world. It was modernized in Soviet Union by Professor Elizarov. And now in most cases, it is called Elizarov's method. But except Elizarov devices, we use the other types of the devices, which allows us to perform a good fixation of the broken bone. And this fixation can be as temporary as well for treating for all the period of the fracture. The special of Elizarov's method was use of thin pins and external for external fixation. This allows us not only to fix the fracture, but also to make different manipulations with broken fragments. It allows us to perform destruction or compression, to move these fracture fragments in both three-dimension planes. It is widely used for open fractures because it allows us to take care about wound. It is widely used for complex fracture with a lot of small fragments. It allows us to receive restoration of length of the bones, and it allows us to make such manipulation as enlarging the bone length. There are different types and different modern types for external fixation, which can be used on lower extremities, of upper extremities, for the joints, and so on. It is well recommended to use these devices in the case of non-unions which are caused by infection, by osteomyelitis, for affected bones by different tumors, and so on. That's how it is looking like. As you see, in this case, it is impossible to receive good fixation by using a nailing or using a plate. So external fixation is a good idea for such fractures, and it can be healed and used for all time the bone until the bone will be healed. What are the main complications of fracture? There are a lot of complications, but I would like to face your attention on such complication as compartment syndrome. It is early complications. The other complications we will be talking about on our fracture lessons. We will discuss osteomyelitis, non-unions, and so on. About compartment syndrome. It is a condition when elevated intracompartmental pressure within a confined myofascial compartments compress the neurovascular function, structures, and it leads to unchangeable changes in the distal part of the affected limb. It develops when the tissue perfusion in the muscle is less than required for tissue availability. In other words, a liquid from vessels is penetrating through the vessel wall into the soft tissues. The edema of soft tissues is compressed the neurovascular structures, and it leads to severe ischemia of the peripheral part of the limb. It can be developed during first few hours after the trauma, as well as it can develop in several days after the trauma. It can be caused not only by a trauma, but also it can be iatrogenic. In the case of surgery, when a doctor, or not only surgery, but in the case of close reduction, when you use not sufficient anesthesia, in the case of surgery, when you use big fixators and you make very close suturing of the wound. When you not use the drainage, it can cause the edema and it can cause the development of compartment syndrome. So always take attention for symptoms of possible clinical compartment syndrome development. It has 6 Ps: paresthesia, pain, pressure, pallor, paralysis, and pulseness. That's why when you are using casts, I told you, try to leave free of cast the peripheral parts of fingers so you can evaluate the pallor of nails and the pulsation, peripheral pulsation. The patients have compliance for paresthesia and pain, and it can be very strong and is not relieving using non-steroids or anti-inflammatory drugs. Patients can have complaints that they feel just ants are running under the skin, bugs running under the skin, or they feel just electricity is stroking them into the peripheral part of their limbs. It is not obliged that patient will have all complex of these symptoms. It can be only the few, and these symptoms can develop on time. So if you see the symptoms, it is very important to take care, to take measures to prevent them as fast as it is possible, because as I told you, the changes will be irreversible. Few words about such late complications as delayed union and non-union. Each bone on our body has its known terms for its healing. When we don't receive the normal healing in this middle time, we are talking about problems with healing, non-union and delayed union. When this normal time is less than twice, it is delayed union. We call it delayed union. When this period is twice and more, we are talking about non-union. For example, such fracture of as we mentioned today, fracture of the femoral bone, yes, it is normally healed for 6 months, up to 6 months. So after 12 months, if you receive not enough healing, we are talking about non-union or pseudoarthrosis. Up to 12 months, when we don't receive enough bony callus, we are talking about delayed union. To treat this, in the case we have insufficient or we have defect of the bone tissue of the bones, which is caused by the trauma or our manipulations, or it is caused by complications, we should restore this defect of the bones. And for this, we can use autograft and allografts as well. Autograft is the bone which is harvested from patient's own body. Allograft is a cadaveric bone, which is usually obtained from a bone bank. Besides, we have a lot of synthetic materials which can be used to restore the absent bony tissue. It is important, and it is impossible to receive a bone healing when we have a bony deficit of the tissue. We always must restore the length of bone, and bony fragments must be touched one to the other to receive the bony callus development and to receive the bony healing. If the bony fragments are not attached one to the other, you will receive non-union in 100%. This deficit, this empty space, will be fulfilled by a scar, by connective tissue, and bony tissue can't grow through the scars and connective tissue. So we always use materials to fulfill this insufficient part of the bones. Thank you for your attention.